Hi, my name is Carl. I'm a paediatric emergency medicine doctor. Today, we are going to talk about eating disorders in kids. In particular, we're going to look at guidelines and tools that can help us with treatment. As we consider medical care in eating disorders, it is important to understand first principles. Whilst this is a condition served best by specialist professionals, you may be a non-specialist involved at any number of stages in their patient journey. In the early stages where a diagnosis is suspected and engagement with care is required, it can be helpful to use the following narrative. Like a car that needs fuel, our bodies need energy. Energy comes from nutrition. Without it, we shut down, just like a car breaking down. Fuel, or in our case, nutrition, is the life-saving prescription. Striving for early cooperation and understanding is important. Take small steps, not giant leaps. There are situations where you, as the first professional involved, may feel certain of the diagnosis of an eating disorder, in which case referral onwards to a specialist is clearly indicated. If, however, you are uncertain, nice guidance may help. Firstly, we need to put down previous stereotypes we might have had in our minds. An eating disorder can occur at any age in a person with a below average or above normal weight, in men and women who may appear well from the outside. The risk is highest between the ages of 13 and 17. Despite a lack of nutritional reserve, they may have a powerful drive to keep exercising, and so may appear energetic right up to the point of physical collapse. Remember to ask about excessive training and exercise and misuse of anabolic or androgenic steroids. Typically, behaviors in eating disorders are hidden. This may be due to shame or lack of insight. While some people may talk openly, others find it difficult to disclose. The fear is that identifying an eating disorder leads to them being forced to gain weight, so they may not accurately describe their condition to you. Professional sports, fashion, dance, and modeling also have added risks associated. Now that we've recognized our own biases and avoided making assumptions, let's consider circumstances to suspect an eating disorder. Firstly, consider an eating disorder in anyone presenting with an unusually low or high BMI for age, rapid weight loss, changes in eating behavior, concern about body weight or shape, compensatory behaviors such as laxative misuse, vomiting or excessive exercise, poor dietary control of chronic diseases such as diabetes or celiac disease, menstrual, pubertal or other endocrine disturbances, any signs of malnutrition, electrolyte imbalance or hypoglycemia. Chief complaints can also include a number of system issues such as gastrointestinal problems, from abdominal pain to constipation to reflux or even hematemesis. The cardiovascular system can also be a clue, where syncope, palpitations or bradycardia may occur. Endocrine symptoms such as secondary amenorrhea or generalized fatigue may be present, and of course psychiatric symptoms like depression, anxiety, self-harm or suicidality. All unexplained subacute or chronic gastrointestinal, cardiac, neurological or psychiatric symptoms should invite the use of a screening tool such as SCOFF for the possibility of an eating disorder. S. Do you make yourself sick because you feel uncomfortably full? C. Do you worry you have lost control over how much you eat? O. Have you recently lost more than 1 stone in a 3-month period? F. Do you believe yourself to be fat when others say you are thin? And F. Would you say food dominates your life? These 5 questions are designed to clarify suspicion that an eating disorder might exist and can be delivered either verbally or in written form. An answer of yes to 2 or more questions warrants further questioning and a more comprehensive assessment. A further 2 questions have been shown to increase sensitivity and specificity, in particular for bulimia nervosa. These 2 questions are: 1. Are you satisfied with your eating patterns? And 2. Do you ever eat in secret? Sometimes referrals are delayed as a result of uncertainty. This flowchart shows the importance of considering an eating disorder in parallel, not in series, with other possible diagnoses. It shouldn't be a diagnosis of exclusion. An eating disorder should be thought about early on. The BMJ has a helpful infographic that provides a helpful framework for assessment, starting with history, thinking about weight, their highest and lowest, and any recent weight loss, asking about eating habits, any avoidant behavior, food patterns, binge or purge episodes. Consider menstrual history in women. An absence of menstruation can indicate malnutrition. Think about a collateral history, obtaining details from caregivers, as patients themselves often minimize symptoms. Patients with eating disorders are at high risk for suicidality. Screen for this. Parents or caregivers can often provide crucial insights into behaviors and symptoms that patients might deny or minimize. Always think about interviewing the parents alone. And of course, include a psychosocial history. Explore different areas of their life and social functioning. Examination should be multi-system and include measurement of weight and height. Pay attention to hair, teeth, and skin. Remember, alternative diagnoses to be alert to include diabetes, celiac disease, hypothyroidism, and malignancy. Concurrent mental health disorders should also be considered, such as depression, anxiety, obsessive-compulsive disorder, and possible alcohol misuse. Some further investigations are shown on the slide. An ECG and blood glucose should be checked, with other tests following as indicated. Depending on your setting, it may be necessary to refer children onwards to other professionals. Know your referral pathways. Consider planned options versus emergency options, but avoid delays and be sure to organize reviews and follow-up if there are long gaps expected ahead. Consider how best to support families whilst they are on waiting lists. Ultimately, for triage and prioritization, we need to risk assess the situation. It is important to be aware that there are a range of serious morbidities, and while some are minor, others, if left unchecked, can lead to death. For example, cardiovascular complications. Severe bradycardia can be common due to autonomic dysfunction. Prolonged QT intervals or torsades de pointe can increase risk of sudden death. Clues of pericardial effusion or cardiac tamponade can be seen in cases of severe malnutrition. And even heart failure and cardiomyopathy can occur due to starvation, whereby there is hypokalemia-related arrhythmias and atrophy. With regards to gastrointestinal serious complications, be aware of superior mesenteric artery syndrome. Here, there can be compression of the duodenum by the superior mesenteric artery in severely malnourished individuals. Esophagitis and Barrett's esophagus are also possible due to chronic vomiting. Mallory-Weiss tears and esophageal rupture can also occur with forceful vomiting. And acute pancreatitis can be the result of repeated binge eating. With respect to endocrine and metabolic complications, hypoglycemia can occur due to inadequate glycogen stores. Hypokalemia can occur due to diuretic misuse and/or vomiting. Hypothermia can be common because of a decreased metabolic rate. And of course, osteoporosis, osteopenia, and even pathologic fractures can occur due to low estrogen and testosterone and inadequate calcium and vitamin D. Lastly, refeeding syndrome is a condition which is life-threatening with low phosphate, low potassium, and fluid shifts upon refeeding. Further complications can affect the central nervous system. Wernicke's encephalopathy, where there is a thiamine deficiency that leads to ataxia, ophthalmoplegia, and confusion. Seizures due to electrolyte imbalances or low blood sugar. And of course, there is an increased suicide risk amongst these psychiatric disorders that coexist. Hematological complications can include a pancytopenia with associated increased risks of sepsis and life-threatening bleeding, including intracranial bleeds. And lung complications can include an aspiration pneumonia due to chronic vomiting or binge eating, as well as pneumothoraces or a pneumomediastinum due to repeated vomiting and an increased intrathoracic pressure. So as we can see, every body system can be affected by these disorders. In 2017, the Parliamentary Health Services Ombudsman produced a detailed report called Ignoring the Alarms: How NHS Eating Disorder Services Are Failing Patients. It identified a lack of experience and knowledge amongst frontline staff. It recognised that communication between services can be poor, and that there are high-risk scenarios where care is transferred between regions, where patients may move house or move school or university. Subsequently, a review of training was recommended, and this prompted the formation of a working group to address the issue. The Royal College of Psychiatry Eating Disorders faculty led the development of guidelines, which first led to the marzipan and junior marzipan guidelines. A similar process followed in the creation of the NICE guidelines. Subsequently, the most up-to-date evidence-based recommendations have been compiled in the MEED guidelines, which stands for Medical Emergencies in Eating Disorders. Pause this slide now. This is the checklist that we should be using when risk assessing young people with an eating disorder. Part of this risk assessment is the calculation of the young person's mean percentage BMI. What is it and how do we calculate it? Let's take the example on screen. We have a girl aged 12. She is 1.5 meters tall and weighs 25 kilograms. We calculate her BMI to be 11.1. And looking at the Royal College of Pediatrics BMI chart for girls, her age, we look at the 50th BMI centile for a 12-year-old. So we go up from the age of 12 and then across to the left, and we see that the 50th centile is 18. Therefore, the percentage median BMI is 11.1 over 18 times 100, and that comes out at 61.7. This is less than 70% and therefore concerning. How about refeeding syndrome? When do we worry? What is it? Realize that our cells and their electrolytes are maintained by cell membrane pumps, which are activated by insulin and require energy to function. In the setting of reduced energy intake, there is a decrease in circulating insulin, and cell membrane pumps become less active. As a result, there can be depletion of intracellular potassium, magnesium, and phosphate, and accumulation of water and sodium inside the cells. This loss of intracellular potassium can be hidden, whereby plasma levels remain in the normal range, whilst whole body potassium becomes massively depleted. A principle that must be understood in order to effectively prescribe electrolyte replacement. Upon providing energy, for example carbohydrates, cell membranes are reactivated, with potassium and magnesium being pumped into the cells and the water and sodium being pumped out. This can lead potentially to a large deficit of intravascular potassium and magnesium. The rising insulin levels also drives phosphate and glucose into the cells, where they again become depleted in the bloodstream. The resulting low potassium, low magnesium, and low phosphate can lead to arrhythmias amongst other symptoms, and have been the cause of death in some refeeding cases. This sudden shift of electrolytes with a sudden release of water and sodium into the bloodstream can lead to edema in healthy volunteers during such refeeding. Heart failure and pulmonary edema can develop, and these can often be the first clinical manifestations of refeeding syndrome, where there is an increased respiratory rate and an unexplained tachycardia. Fortunately, death is extremely rare, but fluid overload is very common. Elements on assessment that suggest an increased risk of refeeding syndrome include a mean percentage BMI less than 70, little or no intake for 4 days, a starting low potassium, phosphate or magnesium level in the blood, a white cell count less than 3.8, a low starting thiamine or low vitamin level, and comorbidities such as infection, cardiac disease, liver disease, or other serious illness. Risk assessment isn't the end of our responsibility. Onward treatment and care follows in all cases and is guided according to risk. See this flowchart below for further guidance. In cases of admission to hospital for treatment, the following are some examples of important principles for those who work in an inpatient setting. Decide early what are treatment goals. Involve patients and carers in management planning. Schedule regular reviews. Be prepared to use legal frameworks. Establish early the necessary level of nursing and provide your staff with training. If progress is poor, proceed as if the patient is engaging in covert behavior and consider how and where they are eliminating calories. Ideally, pediatric wards should not be the place for prolonged stays. Support discharge where possible to community and specialist centres. Here is one helpful account from a paediatrician with lived experience. Young people who require admission to a paediatric ward generally do well when there is a named paediatrician rather than a consultant of the week system, and when nursing staff have an understanding of eating disorders. One-to-one supervision can be provided by nursing staff and/or parents. Involve parents early in meal times. This facilitates timely discharge home. Thank you so much for listening. Next time, we're going to conclude this series on eating disorders in children. We're going to recap the scale of the issue. We're going to think about take-home top tips and remember important pitfalls to avoid. See you then.